Hello, my name is Lydia Wilson, and I am going to be presenting on Group A streptococcal infections, or GAS infections. So Group A streptococcus is from the genus Streptococcus, and it is a gram-positive bacteria. It is non-motile, a mesophile, and they can be facultative anaerobes or obligate anaerobes, and they are usually catalase negative. And Group A Streptococcus actually have hyaluronic acid capsules. So Group A Streptococcus is more specifically known as Streptococcus pyogenes. So these are distinguished from other Streptococcus species through what type of hemolysis they participate in. So Streptococcus pyogenes uses beta hemolysis, it's beta hemolytic. And this means that it completes lysis of red blood cells surrounding a colony. So this bacteria can cause many infections ranging from minor to deadly. So the minor ones are like strep throat, scarlet fever, and then the deadly ones are streptococcal toxic shock syndrome and necrotizing fasciitis. So the strains of Group A Streptococcus are classified based on the M protein encoded by the EMM gene. In a sample from 10 countries, EMM1 and EMM3 were most associated with streptococcal toxic shock syndrome and necrotizing fasciitis, which are two of the most invasive diseases caused by Group A Streptococcus infections. So we're also seeing new drug-resistant strains that are being reported worldwide. So now we're going to talk about the pathogenesis and the virulence factors of Group A Streptococcus. So we have the M protein and lipoteichoic acid, which aids in attachment to the host. And we also have the hyaluronic acid capsule that inhibits phagocytosis. Group A Streptococcus also produce extracellular products like pyrogenic toxins, which cause the rash in scarlet fever, as well as secretions like streptokinase, streptodornase, and streptolysins. So I will be focusing on necrotizing fasciitis as the disease caused by my infection because Group A Streptococcus causes so many diseases like strep throat, scarlet fever, and as well as streptococcal toxic shock syndrome, which I mentioned earlier. But I will be focusing on necrotizing fasciitis. So this is most commonly caused by Group A Streptococcus, although it is caused by other bacteria or bacteria working in conjunction with Group A Streptococcus. It's a rare bacterial infection characterized by warm, red, swollen, painful spots on the skin. It spreads very quickly and it may cause death. It requires urgent medical and surgical care. And a little bit on the etymology of necrotizing fasciitis. Necrotizing means causing tissue death, and fasciitis means the inflammation of the fascia. So every year in the US, we have 700 to 1,200 cases of necrotizing fasciitis in the US. And this is expected to be an underestimate. There were 9,871 necrotizing fasciitis related deaths in the US between 2003 and 2013. Necrotizing fasciitis does not affect any specific age range more than another. No one's more at risk than anyone else for NF, but necrotizing soft tissue diseases are more common for patients who are obese, diabetic, immunocompromised, or alcoholic. So a little bit on the history of necrotizing fasciitis. The first possible description that we have of necrotizing fasciitis, what we think might be necrotizing fasciitis, is from a Confederate surgeon named Joseph Jones. That's a picture of him right there. And that was in 1871 during the Civil War. He had 2,642 soldiers that were infected and they had a mortality rate of 46%. And then our first description that we believe is the most accurate and is necrotizing fasciitis, that we know to be necrotizing fasciitis, is from B. Wilson in 1952. And he observed edema and necrosis of subcutaneous fat and fascia with sparing of the underlying muscle in his patients. So now we're going to talk about the transmission of NF. So since it is caused by group A streptococcal infection, the bacteria can enter the body through several ways, including penetrating and non-penetrating trauma. So non-penetrating trauma would include like bruising or a muscle strain that increases blood flow to an area, and that can move bacteria that's already in your body, while penetrating trauma breaks the skin. So it's possible, but extremely rare to develop necrotizing fasciitis from bacteria that has remained in your system after a previous group A streptococcal infection like strep throat. So if that bacteria travels through the bloodstream and is not attacked by your immune system, then you do have a chance to develop necrotizing fasciitis. But don't worry, it's very, very, very rare. And here's a picture of what necrotizing fasciitis kind of looks like on an arm there. So now we're going to talk about prevention. We have chemoprophylaxis, and that is when a physician may prescribe a precautionary antibiotic to anyone who is high risk, who has had contact with necrotizing fasciitis. But this is really rare, as necrotizing fasciitis is not often spread and you don't want to overprescribe antibiotics. Another great prevention tactic is good wound care. So if you have any wounds that have broken the skin, really making sure to have proper cleaning and care of those wounds can really prevent necrotizing fasciitis from happening, as it prevents bacteria from entering in and entering your wound. So now we're going to talk about the symptoms and description of necrotizing fasciitis, because I talked a lot about the other things, but now we really need to get into what it really happens when you have necrotizing fasciitis. So the initial symptoms are actually pretty vague. You have fever, pain, swelling, and redness. And so this is often underestimated or mistaken for something else like cellulitis, which cellulitis is also caused by group A streptococcus. So it's easy to mix up. But then 48 hours after the onset of your initial symptoms, 24 to 48 hours, you might have duskiness of the skin and gangrene, which indicates that the vessels of the dermal papillae have clotted, and also that your superficial nerves have been destroyed. And then once you enter the advanced stage of your disease, your symptoms are a little different as well. You have large blisters with clear fluid, and you might have cracking or grinding sounds of your bones rubbing against each other because of a lack of tissue left. You also have loss of sensation and necrosis, and lesions on your skin will resemble third-degree burns. So once you enter advanced disease, you could go septic or go into shock, and many patients also experience organ failure, and also, unfortunately, this can lead to death as well. So now we're going to go over what actually needs to happen to get a diagnosis in necrotizing fasciitis. So the most effective diagnostic tool for necrotizing fasciitis is surgical exploration. So really just going in there and getting all this, the infected tissue out. They also do gram stains to confirm that the bacteria causing the necrosis is group A streptococcus, so that they can target treatments towards that. They also might do a culture. So a CT scan or an MRI might also be helpful to detect subcutaneous edema or tissue gas. Now we're going to talk about treatment. So like I said before, the exploratory surgery is a diagnostic tool, but it's also a treatment. So you want to get in there and remove all the dead tissue as well as some healthy tissue to ensure complete removal of the infection. And this will also be paired with broad spectrum antibiotics based on that gram-stain conformation of group A Streptococcus. So this would look like high dosages of penicillin, ampicillin, or clindamycin, which kills group A Streptococcus, clindamycin, excuse me. Not much more can be done after these though, but they are pretty successful. The mortality rate is 24 to 34%. But when necrotizing fasciitis is occurring with Streptococcus toxic shock syndrome, mortality rates rise to 60%. Amputations are not uncommon as a last-ditch effort to save the person's life and get rid of that diseased tissue. So for future outlook and future research on necrotizing fasciitis, we're not really at a risk of an outbreak as necrotizing fasciitis is pretty rare and it's not commonly transmitted at a high level or even at a medium level. More research should be done though on the drug-resistant strains of group A Streptococcus that we have seen emerging. And research also needs to improve in the imaging techniques for early detection of necrotizing fasciitis. It is possible that some of the vaccines in development for group A streptococcal infections like strep throat and scarlet fever could be beneficial, but there's not enough research to really know at this time whether that could be helpful in the prevention of necrotizing fasciitis, or if it would just be specific to strep throat and scarlet fever and the less invasive diseases caused by group A streptococcal infections. That's all I have. Thank you for watching.